Hello, everybody, and welcome to Community Conversations here at Atlantic Health System. My name is Luke Margolis. I'm the Corporate Communications Director for Atlantic Health. And for this episode, I'm excited to be joined by my two guests. To my left, your right, screen right, if you will. They are Dr. Colleen Coughlin, she is at the far end of the table, and Dr. Claire Bossia. They are both members of Atlantic Health System's Women's Heart and Adult Congenital Cardiology Program. Did I get that right?
You did.
All right.
Thank
So far,
you.
so good. One
Thanks
for
for
one. Well, thank you both for joining us today.
Thank you for having us. It's really a pleasure.
Yeah, we're happy to be here to talk about our program.
And we're looking forward to a great conversation. For those who have not yet tuned into a community conversation, I'll give you a little bit of run of show real quick. The doctors and I are going to have a conversation, and we'll go on for about 15 minutes to a half an hour, somewhere around there. But this is not just an isolated conversation between us. You have a role to play here as well. If you hear something that you want a little more information on, feel free to drop a comment or a question into the chat section below the window, and we will try to get that question answered as quickly as we can. We have a lot of questions to get to. As part of our process, we usually let folks submit stuff ahead of time, and we have almost 2 pages worth of questions. So there's a lot of interest in this topic. So I want to get to those as quickly as we can. But first, if you have to bail out on this conversation for whatever reason, the entire thing will live on our Facebook thread. It'll also be on our other social media channels, our website, atlantichealth.org, and you can see this on television on News 12 Plus, Saturdays and Sundays from 8:30 to 9. So that is sort of the full gamut of options available to you. Let's jump right in. First with a simple one, or maybe not so simple, let's see. The Women's Heart and Adult Congenital Cardiology Program. What is it? And we can, Dr. Coughlin, can start with you and move to Dr. Bossia. In your opinion, how do you start?
I think you should go first.
Oh,
I like this.
wow. Well, I think it means a lot of things to both of us, but
Sure.
but it's a funny mix because we have both specialties included. But we really are on the women's heart end. We're seeing women from ages 18 to, I think our eldest is 102 now.
102.
Wow.
And we really are trying to serve women's heart health needs throughout their lifetime. And you might say, what makes heart health for women different from men? And there are some unique things like heart conditions that affect pregnancy, and also even things as basic as how coronary artery disease or hardening of the arteries happens for women versus men can differ. So it's tailoring prevention and treatment of heart disease to women's needs.
For those who are learning a lot about Atlantic Health System through our program, Atlantic Health System's heart program in general and cardiology program is nationally recognized, and certainly you can learn a lot more about that at our website, atlantichealth.org. You can go there and type in cardiology or any of the terms you hear referenced today in the search bar there, and you can learn all about this award-winning program, and Drs. Coughlin and Bossia are part of that, but there is quite a lot, and quite a lot of expertise no matter what heart condition you may have. Dr. Coughlin, to expound a little bit onto the program, I guess give us a little bit, if you can, just a little bit of background. How long have you guys been involved in it? How long has it been around? And how aware are patients of it, or are we still sort of helping folks learn about the different options available to them?
Yeah, so I think I came in 2016 to join Dr. Bossia, who's been there for quite a few more years than that. Not too many, but
I think 2012 was the inception.
so,
Awesome.
so almost 10 years. I feel like it's a really unique place to take care of more women than men. We do see some men. A lot of them happen to be the spouses of the patients that we see. But I tell people a lot, when I was in medical school, women didn't get heart disease. And it wasn't until early in my training for internal medicine that we realized it's the #1 killer of women. And in that way, we have an opportunity to try and ferret out data that's coming up about what is the difference between women's heart disease and men's heart disease. And we have learned a lot about the hormonal aspects of women's heart disease, and we keep learning about it. It's something that is gradually unfolding, but we feel like we're kind of on the forefront. And so it's been very exciting. We take care of women that have breast cancer and they have hormonal therapies. And they get a little more complicated. But there's heart disease that happens more likely in women that we see, and also autoimmune diseases tend to affect women more than men, and they come with their associated heart disease as well. So I feel like we have interesting work to do every day. We are always excited to talk about what patients we see and what we can do to help them, serve them better, and enjoy learning. Both of us like to learn and keep ourselves challenged pretty much every day.
This journey, the age range you mentioned, Dr. Bossi, was 18 to
102.
102.
Yeah.
Okay, so
God bless her.
yeah, amen. And power to her. But that age range, I'm sure, must come with the differences in the patients that you see and the challenges therein. What can you, for our audience who may not know anybody of that age or on the higher end, can you describe some of the challenges that come with trying to help folks navigate this heart health journey along such a wide range of ages?
Oh, sure. It's great because there's never anything boring about what we do. There's such a diversity of women. But for example, some women have irregular rhythms of the heart. They are hormonally mediated and more apt to happen during pregnancy or during menopause. So that's two areas of your life, that where we're kind of on the radar. In older women, typically, more commonly, if she develops heart failure, the type of heart failure she might develop over the age of 65 or 75 is called diastolic heart failure, or a stiff heart that has a hard time relaxing. That's a particularly challenging type of heart failure to take care of. So that's sometimes an unfortunate milestone of that age group, and so we're attuned to that and kind of working with women where they are.
It must be rewarding to see that progression and to be with patients over the course of time.
Oh yeah, no, the longevity is nice.
So as I mentioned, we had a number of questions submitted to us ahead of time for this discussion. So I want to start with those, but if you hear something that you want a little more information on or have a separate question we haven't addressed yet, feel free to submit it as well. I want to start with a question that was submitted to us by somebody named Jackie. And this touches on a little bit of the hereditary nature of some of the work that you may do in working with families. Jackie says her mother, her father, and brother all died from heart attacks in their 60s. Now she admits this was quite some time ago and that heart health and heart care certainly has evolved over time, but she's curious, in addition to the new resources that may be available now that weren't available to her relatives then, how important is hereditary information? She eats right, she exercises, and she maintains healthy weight, but is some of this stuff, in terms of your heart health, carved in stone by your genetics? What would your reaction be to her then?
So sounds like she's doing a lot of the correct things to maintain a healthy weight, to not smoke. She didn't mention that, but all the pillars of good health are present. But sometimes, despite you're living a healthy life, there are other things that can cause problems. And we often do what are called coronary artery calcification scores, because that's a good way to risk stratify somebody, to see do they actually have plaque buildup. And that way we can tailor their prevention strategy based on do they have coronary artery disease or not.
And risk stratify basically is help them identify where they may fall on that spectrum in terms of...
So we may see a patient that has a family profile like that that's concerning. They're active, they don't have any symptoms, and that way we can say, hey, I say it's individualized risk assessment, because we have a lot of risk assessors that you can plug in numbers, but they don't often factor in the other things. For example, when a woman has a preeclamptic pregnancy, that puts them at higher risk. And we talk a lot about that is pregnancy is a way to identify what might happen later, or called a failed stress test. So someone may have all the features, a healthy lifestyle and so on, but if they've had a preeclamptic pregnancy, they may have an elevated coronary calcification score, and the women are just by the fact of that. And and also that's true for women that have gestational diabetes. That those are things that say it's a failed stress test, and those women should be have individualized health plans to get them to reduce their risk.
Dr. Bossi, Jackie had a second question that I'd like to touch on as well. In terms of parents watching out for their children, how important is it that she share this history, this family history that she may have, with her children? What can parents do for their kids to keep them informed so that they can live healthier lives too.
Absolutely. What she can do is be upfront with it early. I think we think of coronary artery disease or heart attacks as happening to older people, but it's actually a slow-growing process and a culmination of our lifestyle that starts in our teens. It's a pediatric issue, not an elderly issue. So. I think Dr. Coughlin was bringing up a great point when she talks about prevention, is that leading by example with your kids and trying to introduce healthy vegetables and fruits and a relatively low simple sugar diet, avoiding avoiding trans fats and things like this, are really helpful in showing them, not just telling them what to do. And also, I think if people utilize the coronary calcium score earlier in life, in middle age rather than later in life, to again get a glimpse of, hey, where do I stand in terms of how my arteries doing? Are they building up with hardening of the arteries, so to speak, or are they doing okay? That's helpful. So having an awareness early in life, modifying these risk factors that we've been talking about, encompasses about 80% of your risk. So it's empowering young people to change the course of their lives, so that they don't feel like they're just destined to follow in the footsteps type of thing.
That's hopefully reassuring.
I was just going to throw in a study that came out a few years ago in the New England Journal of Medicine that looked at people who were genetically at high risk for coronary artery disease, so the hardening of the arteries. And if people lived a healthy lifestyle, maintained healthy weight, didn't smoke, active, ate well, they reduced their risk of coronary artery disease by 50%. And to me, that's just a very optimistic thing, that although you have a genetic tendency, you have some control over it. And similarly, those patients that had low risk from a cardiovascular standpoint, if they didn't maintain a healthy diet, lifestyle, healthy weight, and didn't smoke, they doubled their risk. So that's the whole concept of epigenetics and how our environment affects how our genes are transcribed.
Susan on Facebook, who's watching now, thank you, Susan, asks, if you've had an aortic valve replacement, are you more susceptible to heart disease than normal?
That's a great question. I think the way you define heart disease is the tricky part here. If what Susan's talking about is narrowing of the arteries of the heart with cholesterol, having just had an aortic valve replacement doesn't necessarily put you at a higher risk of that accelerating after the replacement of the valve. But part of that question is, what is heart disease? And it's a big basket. It includes hardening of the arteries, or coronary artery disease is about 50% of what we talk about when we talk about heart disease, but there's also electrical problems of the heart, that's like atrial fibrillation or irregular rhythms. So those are rhythm disorders. And there are also valvular heart disease, where her heart disease falls in at the aortic position. So
and pump failure. You were talking
and
about
pump failure,
that,
that's
too.
right. I forgot our fourth category, pump
It's
failure.
like building a house.
Right. We're talking about all the systems here.
The general contracting of the heart.
So yeah, while she'll always have valvular heart disease, it's not set in stone that she'll develop coronary disease as a result of it.
Got it. Susan, thank you for submitting the question. And this, Jeanette actually asked something that's similar to where our conversation was previously around the things that you can do that impact your heart health. Nutrition. How important is nutrition as we're talking about heart disease? Are there foods, to your knowledge, that, and this may straddle into other different areas of expertise, that help or hinder heart health? She references nuts specifically, but are there other dietary issues that people need to keep in mind when they talk about their heart health?
So yes, there are. Definitely, I use the term, instead of fruits and vegetables and fruits, because anything that has higher fiber and lower sugar content is probably better for somebody. But if you have a hankering for a sweet, it's probably better to turn to an apple or an orange than their local cookie stand. But so anything that's high in fiber is definitely helpful for us. And there's been quite a bit of literature. The American College of Cardiology has gotten into making statements about animal protein. And we had the former president of the American College of Cardiology, who helps write the guidelines for prevention, come and speak to us about the importance of reducing saturated fats, of which a lot of them come from meat. So trying to decrease, he'll say, get rid of any animal protein. The most recent guidelines say fish is okay, but we should probably get rid of the other sources of animal protein. So in my mind, people have to figure out how they feel best, and nuts is a good workaround for getting adequate protein in your diet if you choose to not eat the saturated fat from right. But so those are definitely important. I tell people the average American eats about 10 grams of fiber, and we should be eating about 30 to 40 grams. So that's not to say that tomorrow to go out and buy a whole bunch of lettuce and eat nothing but that, because you will not be happy.
I don't think we're going to do that.
But gradually to work
Personally
that in,
speaking.
you know, to be mindful of that stuff. But certainly reducing salt is another aspect of it. And Dr. Bossia had mentioned about simple carbohydrates, that we all eat way too many simple carbohydrates, and by adding more complexity in our carbohydrates, it doesn't bombard our metabolic system, so that we're not as likely to get diabetes. But fiber also helps escort cholesterol out of the intestinal system to lower it in a
That's a great way
healthier
to
way.
put it.
Jeanette, thanks for the question. I'm wondering, Dr. Bossi, you mentioned that the program has been around since 2012, I think you said.
Yeah.
Can we talk about just the evolution of heart care over that time? Would folks be surprised to see how much the field has advanced in just the last, 9 years, give or take?
Oh, absolutely. I think, you know, we were on a trajectory when we talk about heart disease being the biggest killer of women. Mm-hmm. We were constantly having to give the terrible statistic that women's heart disease death rates were doing this, men's were doing this, and we were still dying at higher numbers than men. And I think that over the last 9-10 years, what I'm really seeing is that there's now more parity, and we're starting to reduce that curve for women, which is an incredible accomplishment, of a nationwide push. But it gets down to the weeds in our program of trying to find women at highest risk and address their needs, and let them get education, awareness, and treatment. So I've been really happy with that statistic. I think we are learning more and more about a syndrome called broken heart syndrome, or Takotsubo's cardiomyopathy. That is a sudden weakening of the heart muscle, we think, from stunning of the heart, where blood vessels in the tiny areas, the tiny blood vessels of the heart constrict. Okay. And for reasons that are not fully understood, that happens 9 times or more frequently in women than in men. So understanding that, when I was, I'm dating myself a little bit here, but okay.
We all tend to do that on this show.
I was in training at least 15 years ago, so at that time, that was kind of a newer entity being talked about, and I don't even know that we really understood that women were more afflicted by this problem than men. Now this is in our training program where we teach cardiologists and training fellows. This is common parlance, and they understand and target women and suspect it in the emergency room when they see it. And I think it's a wonderful evolution, because and I always say this, when we learn to treat people, gender-specific medicine, when we learn to treat women better, we ultimately learn more about men's heart disease as well, and we end up tailoring.
Oh, can I just throw in
please.
something else? So speaking of evolution, so one of the things that Dr. Bossia is really working hard on is the adults with congenital heart disease. And there has been a huge evolution in the treatment, the survival and treatment of congenital heart disease. Decades ago, children born with holes in their heart didn't live to adulthood. And now that surgical techniques have improved so much that these young people are now living to adulthood and thriving. Some young women we've even seen who've had significant congenital surgery and have been able to have babies of their own. And it's a very gratifying thing to see people not only survive, but to thrive. And so we're lucky to have Dr. Basia here that has an expertise in this area.
Amen to that. Okay, we have a couple more questions that are coming in live and that we have here submitted ahead of time, but I want to touch on one thing before we get to those. Let's talk about how the pandemic has affected how, if at all, how you deliver care and some of the things that you're seeing. That's a leading question there, ladies and gentlemen. So let's talk a little bit about that. How has the pandemic changed the way we deliver care, or what you're seeing in terms of the patients who you do interact with? And whoever wants to go first, I'm sure there's plenty of material there for us all to talk about.
Oh, I think we both need to, yeah.
So just to give a little background for the patients that we take care of, we left Gagnon, which is the heart hospital at Morristown, and we moved to 111 the week before the pandemic broke out. So
111 Madison, which is across the
111 Madison, right. And so there was a huge change for us. We were getting, unpacking our books basically on our bookshelves, and all of a sudden everything shut down.
Wow.
And it was a little bit tough, and we quickly changed to virtual visits as best we could. Dr. Basia was brave enough to go work in the COVID units. She volunteered to help care for a lot of the critically ill patients, and I held down the fort in our new office, and we were able to take care of a fair number of people who had critical problems but were afraid to go to the ER. Sure. So we could function in a way to at least triage, to say, hey, this is pretty serious, or hey, we can manage this medically here. And I think it made a big difference for patients. There's a lot of people, because of stress and everything else, their blood pressures have gone out of whack. A lot of people are suffering because they're by themselves, and there are stress-related problems that are a result. People are sitting home, eating poorly, not exercising, and paralyzed, really, to be quite frank. But I feel like when the summer started to happen, things started opening up again, and I think people felt more confident that we were going to care for them. So everybody gets their temperature checked as they enter the building. They know that everything is wiped down meticulously. We all wear masks. We're very respectful of their concerns too, that we try to alleviate their anxiety about getting health care, and that we can keep moving their healthcare issues on despite the pandemic.
Yeah.
Dr. Basia, anything you want to add to your experience?
Yeah,
and thank you for your work with the patients who have COVID.
You're welcome. Thank you. And just along that line, as as there had been this kind of pent up need, where we were trying to take care of things virtually. Once the summer passed and we went into the fall, for me as a healthcare practitioner, what was really hard was to walk into the room after I hadn't seen someone in a year and a half. You can't just say, "Hey, how's it going? What's been going on?" There's a lot of emotion. There's a lot of water under the bridge. There was a lot of loss. There was a lot of loss in my family and in the families of the patients I was treating, and so there was we needed time to reconvene, so to speak. But I think that was healing and helpful. We also, on a medical level, are participating in the COVID recovery program here for sufferers of the COVID long haul syndrome, and we participate in the cardiac component of that, in which we're seeing a lot of patients with dysregulated heart rates. Their heart rates are skyrocketing when they're trying to walk.
Dysregulated being either super fast
or super slow, but nothing in between. So we've seen that as a post-COVID condition. So just to name one. So it's been very gratifying to work with the COVID long haul program pulmonologists who've really spearheaded the program and are getting all disciplines of medicine involved in trying to help patients moving forward with the multiple issues that happen in all their organ systems.
If folks are interested in learning more about that program, perhaps you have somebody in your life who is suffering from some of the long haul effects of COVID, or you yourself just maybe are or want to learn more, you can find out more about that at our website as well, which is, again, atlantichealth.org. There is links to all the COVID information that we have right there on the homepage of our website. You can't miss it. Okay, so let's get back to some questions because we just have a couple of minutes left. Here's one that I think is a nice general broad one across a variety of different areas. Other than an annual EKG, what do you recommend for a 61-year-old woman with no known heart conditions? And Lori, thank you for submitting that question ahead of time. So again, general sort of upkeep.
Well, I recommend everyone have a primary care provider that looks after their general health and trying to screen for other conditions that might raise the spectrum of heart disease at a higher level. So the traditional risk factors like history of smoking, diabetes, high blood pressure, obesity, the family history we were speaking of earlier. And then I pretty much ask everybody, what is the most strenuous thing you do in your daily life to get an idea of what their exercise tolerance is, because that can unmask a lot. And has anything changed in the last 6 months to suggest there might be blockages? But I think if there are additional risk factors, a coronary calcification score that we were speaking of is a really good way to help the risk stratify somebody.
On the other side, let's say, well, Lisa asks, what are typical signs that women exhibit when suffering from a heart attack? So, Lisa, thank you for submitting this important question. Are they different from the symptoms that men traditionally show? And if so, what should women be looking out for? Dr. Bassi or Dr. Conklin, whoever wants to.
Sure. I think that we have to make sure that we don't make it an all or nothing. It's not that women never experience that typical thing that we talk about that men have of retrosternal chest pressure or a vice-like feeling in the chest. Men can feel that, women can feel that. In addition, many women can feel jaw pain when exerting. So they're working out, and instead of feeling a chest pressure, it's going to be a jaw tightening. Not to say that can't happen to a man either. It's just quite common in women. Or pain between the shoulder blades. And in older women, sometimes it's just a generalized fatigue way out of proportion to the daily activities that older individual is accustomed to. So we do pay attention to the jaw tightening, to either nausea with exertion. Am I missing anything?
Yeah, sweatiness unexplained is another common thing that we just try, again, eliciting what their daily activities are like, and is anything making the bed all of a sudden becomes a little more challenging, or going up the stairs, or
so
things that
regular routine daily activities or something that all of a sudden become
a little more challenging, or they notice a difference in their ability to perform those. Yeah. But I think the idea of women often have the same symptoms, but they may not present with chest pain. They're less likely to present with it, even though that is the #1 symptom for women. Yeah.
We have, again, a couple of questions that have been submitted live. I don't think we're going to get to everybody's, but I'm going to try to continue to move through. Monica on Facebook is asking about, well, it's a sort of a two-part question. There's a bit of the way we're addressing health disparities. So how are we providing heart disease care and information into what are traditionally considered underserved communities? But do conditions, heart disease conditions, appear differently in different communities and in different ethnicities? What are some important pieces of information we can share with our audience there?
Dr. Coughlin's done a lot of work in that area, so I'll defer.
Perfect.
So we were talking a little bit about preeclampsia, and that being kind of like a life stress test for a woman. Linked to that heavily is the maternal mortality in New Jersey. We're very high in terms of maternal mortality, and African American women are 4 to 5 times more likely to die with childbirth than a Caucasian woman. And in that way, we're trying to target programs to educate about what are the signs and symptoms of preeclampsia, and make sure they get adequate care through our OBGYN colleagues, and if we can help, we're happy to, but also to identify early on so that we can come up with prevention strategies for them to live the full life that they should.
Excellent.
But it's definitely something that we continue to tease out.
And I know that our community health teams are working hard to reach out to many of those communities who are
And we have done talks to try and talk about what is hypertension in women about, and to try and find ways to reach communities that don't necessarily have the same understanding about it.
So if anybody is interested in learning more about those or receiving more information, feel free to reach out to us, and we'd be sure to connect as well.
I also think we have a resource to offer in Women Heart, all one word, womenheart.org. We are a national sponsor of Women Heart, which is the National Coalition of Women with Heart Disease. And we have volunteers who've been through many of these diseases we've discussed today and gotten through their illnesses and beyond, and counsel women, educate women. And these are also women of color. So I think that really helps when you have a woman who's been through it trying to tell you either how to prevent it or helping you to live a healthy life with heart disease.
Excellent, excellent. Well, we are just about out of time, folks. We are right up along our half an hour limit here, and I know there's so many more questions that we've received, some that have come in live and some asked in advance. And I'm sorry we weren't able to get to everything, but we tried to get to as many as we can. We will have our folks who are helping moderate our discussions try to provide more information as best we can. And of course, I would encourage everybody who's watching to go to atlantichealth.org, where you can find a lot more valuable information as well. On behalf of Dr. Coughlin and Dr. Basia, I'm Luke Margolis. Thank you both for joining us today. This was fabulous.
Yeah, thanks for having us.
It was fun.
Excellent. All right, folks. Again, you can find the rest of the conversations on our website, on our social media channels, and at News 12 Plus. Thanks so much for joining us on Community Conversations, and we'll see you next time.